Thank you, Dr. Raghu, and thank you to the team at Bombay for having me all over from Bangalore. Few disclaimers to make. It's the first conference in, I think, for the past 9 or 10 years that I've attended that my talk is actually starting on time that it is scheduled to start at. Okay. I've never had a talk which was scheduled to start at 2 and I'm starting bang at 2. So thank you very much for that. Yeah. So secondly, this talk does not have a single video, does not have a single photo, nothing to stimulate anybody's adrenaline, no ultrasound, no fluoroscopy. Okay, so just to fall short of telling you that the talk may be boring, but the idea of doing this talk is to answer or ask ourselves one question, right? It's very nice to do interventions. It's a great thing to do. Trust me, I do interventions very frequently in patients with cancer pain. It's a very nice thing to do intervention, but we have to ask ourselves every time we do an intervention. And the question that we need to ask ourselves is, am I doing the right intervention in this patient? Number two, if I do this intervention, will this patient benefit? And three, how justified am I in doing an intervention in this patient? To answer all these questions, there is only one answer, which means we should know what intervention would benefit a patient most. That is, what are the outcomes of doing interventions in patients with cancer pain, right? Right. So needless to say, we've been talking about pain all afternoon, right? Painful Sunday afternoon. We're saying pain, 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 pain. Yes, pain, this pain, that pain. We're doing. Yeah. So it is in fact the most distressing symptom that cancer patients have. Okay. And 2/3 of them with lung cancer have pain either because of the treatment or because of the disease or a combination of both. So what does giving patients good pain control help with? It increases their cooperation or their willingness to participate in treatment. When I was preparing for this lecture, I found out that especially in lung cancer, the dropout rate is close to 7.5%, which is a huge number. Given how prevalent lung cancer is in certain subsets of population, 7.5% of patients drop out from treatment purely because of the pain or the side effects from the treatment. They're not able to manage it, not because of financial reasons, but because of all these things. So if you can somehow create an ecosystem where your patient is willing to participate in the treatment, then I think you've done the patient a whole lot of good. It also helps his or her motivation to live and live longer. So, and that has a definite positive effect on his overall outcome. So in such patients, apart from other symptom management, we should give significant control or priority to managing his pain. I'm sorry, I'm not a chauvinist. I use the word his purely out of reflex. It could be his or her. Okay. So this is a very familiar WHO ladder, which we all know. Okay. And the 5 principles guiding the WHO pain ladder, which means we give medicines by the clock, by the mouth, by the ladder for a particular individual. And then we pay attention to every little detail that the patient has. It could be the side effect profile, it could be the analgesic profile, whatever it is, we're paying attention to this. Now, if you see, this is pain ladder stops at step 3, within which there is no role for anything beyond this. So what happens to this group? And it says free of pain. Now, all of us as practicing pain palliative physicians, how many of us see patients who are free of pain with just this? And let's be honest to ourselves, we will not get this set of patients. There will be some patient, in fact, most of the patients will have some pain, will have some side effect. So these are patients. So this free of pain is actually a misnomer. It doesn't really exist. Okay. It's like having an ideal wife or an ideal husband. Yeah. Ideal wife or ideal husband. Both, right? It only exists in literature. Doesn't happen in reality. Right? So that's where a 4th step hasn't yet been added, but a proposal to add a fourth step is being made. And what constitutes the fourth step is the role of interventions. There could also be involvement of neurosurgical procedures. So ideally, this should have come somewhere here. Okay. So you can use epidurals, there are implantable pumps, there's kyphoplasty, there's nerve blocks, there's alcohol neurolysis, thermal neurolysis, radiofrequency, and the gamut is increasing by the day. We speak of cryoneurolysis now, right? So this option, this subset of interventions available to treat these patients is increasing every day. Now, question is, should this be ideally in this place, or can this come anywhere down the line here? Okay, so this is what we will try to understand as over the next, it says 19 minutes, but I'm sure I'll finish it much before that, right? So that we can all go and have lunch. So the whole idea is it gives the patient a significant amount of either immediate or long-term relief of pain. And two, a lot of them who have medication-induced side effects should be in a position to get relief from those side effects, at the same time have relief of pain because of this very important step that is there in managing such patients. Now, this is a review from Vickers which is released in 2011 in Pain Practice, and he spoke about the evidence that is currently available in literature. Unfortunately, this evidence level has not been updated till today. So we go by the Vickers level of evidence. And most interventions in palliative care have only a weak recommendation. And this is primarily because there are not enough randomized controlled trials. There are not enough meta-analysis to show that doing X intervention will benefit Y patient. Okay, so therefore, purely on the fact that there are inadequate studies to show what we're trying to show, the level of recommendation is level 2. Okay, and of which the most important, or the intervention that actually has proven to be very beneficial in patients with cancer pain has nothing to do with today's lecture, today's workshop, but it is celiac plexus block for pancreatic neurolysis. Okay, the rest of all the interventions that we do are either B or C. Unfortunately, some have no literature available. Okay, so but if you see most of them, for example, intrathecal delivery, epidural medication, kyphoplasty, vertebroplasty, all have at least a B+ to C level of evidence. Of course, with time, we hope that, and with better research, we will get more insight into how effective it is going to be. Now, what are the factors that affect cancer pain? Age. Okay, age is found to be increasing age has found to be showing a negative impact on the pain. Rather, the greater the age is, the lower the pain tolerance capacity, so the more the pain. Females, again, not my word, this is from the article, you can quote the article, more prone to suffer more pain, especially in lung cancer. Lower socioeconomic status, primarily because they do not have access to the care required for alleviating their symptoms or the disease. Higher number of comorbidities, and type and phase of cancer. Okay, these are, I think this comes more out of common sense than anything. Now, when I looked up as to whether there wasn't any article or anything that I could look up on the factors which influence the outcome and which can predict the clinical response, this is only one article which is published in Pain Physician 2020. Okay, so we'll go through this article in a little bit of detail to understand what they did. So this was a retrospective study that they did, okay, in where they chose 398 patients who received interventions over a 2-year period. Okay, now 126 patients of the 398 had some sort of an intervention being done. By intervention, I meant some needle put some part of the body. Okay, and of which they included 82 who fulfilled their inclusion criteria, and about 44 people were missing. And they found that, So they had, of the patients that there were 82 patients that was included. Most of them had GI cancer, about 12 of them had lung, okay, and the rest had cancers everywhere else. So the most common blocks that was performed were spinal blocks, which I'm presuming was either an intrathecal or an epidural medication, okay. A lot of them, I also had a peripheral nerve block done. Some had intrathecal sorry, catheter placement. So a lot of these procedures were done. Okay, so like I said, out of 126, they had included 82 patients, and most of them had metastatic disease at the time of presentation. Okay, now what they found was that intervention, and they classified patients into two groups: patients who responded or patients who did not respond. Patients who responded were called responders. That means their pain score came down by more than 50%. And the ones who did not respond were called non-responders. So the responders were about 80%. Okay. And all of them had pain score which had reduced by more than 2 points. Okay. 43% had 50% relief of pain, or more than 50% relief of pain. They also had a significant decrease in fatigue, depression, anxiety, drowsiness, and showed an overall sense of well-being. Their opioid requirement reduced by around 60% on average. None of the analyzed variables correlated with the response. So this is because the concept of pain is a total pain. You're not only dealing with the physical aspect of pain. Okay. So therefore, psychosocial variables like anxiety and depression showed a non-significant trend towards predicting procedure failure. So this was the outcome of the study. Okay, so just to elaborate on the result, so they found that the greatest improvement in terms of what the ESAS variables were was in improvement of pain. Also, there was significant improvement in the fatigue. But also if you look at the other symptoms like nausea, depression, anxiety, there was improvement. Okay. But the greatest improvement was obviously in the pain as well as the fatigue. Okay. So, like I said, most of them had reduced opioid consumption, improvement of the fatigue, improvement in the depression, improvement in the anxiety, and an overall sense of well-being. Okay, this is the opioid consumption. Needless to say, the responders had a better opioid consumption. Rather, the requirement of opioids had gone down significantly in them. Okay, so what they found was patients who had higher fatigue and higher depression scores initially were less likely to respond to interventions. Okay. So, but of course, you need to have better studies to validate these findings. In another study that was done in published in 2018 in Supportive Cancer Care, and they looked at what are the factors that could predict the efficacy of a neurolytic celiac plexus block in unresectable pancreatic cancer patients, and what is the importance of timing it. So they recruited 112 patients. 42% of patients showed good analgesia. And these 42% patients who were called responders were either ECOG 1 or 2, or the higher the ECOG score, the lower the responder. They initially were using much lower opioid dose, had lower serum calcium, CA19 levels, and a shorter duration of pain. And it was found, when analysis, they found that lower ECOG score and patients who had lower opioid usage were independent predictors of good analgesia after neurolytic celiac plexus block. So the conclusion was, offer this intervention much earlier in these subset of patients. Don't wait for pancreatic cancer to metastasize all over and then offer the intervention. As it is, pancreatic cancer patients present was very late, right? So do not wait for them to go to that stage. Early diagnosis, early intervention. Another meta-analysis which was published in Cancers, where they spoke about what are the clinical and critical aspects for showing the outcomes, right? And they analyzed multiple RCTs, which involved doing neuraxial anesthesia procedures, vertebral augmentation procedures, sympathetic blocks, peripheral nerve blocks, and percutaneous cordotomy. And what they found is the relief of pain was good in all of these procedures in majority of the patients. Okay. However, some procedures had significant side effects. Okay. For example, patients who underwent cordotomy, right? But most of them had lower incidence of side effects. However, is this enough for us to put our foot forward and say that these patients should be offered these techniques? No, not yet. Okay, so what we know is it will work. Are we sure that this is going to be the end all, no all for them? No. Are we sure that over a period of time, 5 years, 6 years, 7 years, this is going to keep them pain-free? No. Okay, because most of our patients do not survive that long. And that limits the possibility of you making a statement to that effect. So what are the possible predictors for good outcomes? Needless to say, careful attention of technique. Choose your, and if you have the right equipment for it, you have the ultrasound, you have a biplanar CM, fantastic. It definitely goes to improve the outcome. Should be able to perform this procedure with good dexterity. Sufficient logistics and staff skills. Most importantly is when there is an appropriate indicator, okay, and when there is an accurate clinical diagnosis. If the pain is well defined or it's localized, obviously the outcomes are going to be much better. Okay, and then you also have to do a risk-benefit ratio. Okay, so talk to your patient about the possible risks or the possible benefit. So to take home what I've been speaking for the past 10 minutes, ideally, it is the intervention step needs to be incorporated in the WHO pain ladder, but there is still a doubt or a debate as to when it should be incorporated. A definite selection of patients is a must for good outcomes. Timing of intervention, absolutely critical, needless to say. And more importantly, and I would be very happy if we could all go back with this line. You should recognize what is a successful procedure versus a successful outcome. You put in a needle, you give your dye, the dye is spreading beautifully. You finish, you give whatever you want to give, alcohol, local anesthetic, steroid, phenol, whatever you want to give, you come out. And the patient says, Sab, dard waisa hi hai. Right? So it's a failure. At the end of the day, it's a failure. So remember that a successful procedure need not relate to a successful outcome. Okay. And obviously, we need to do more research on this. With this, I'd like to end my talk. Thank you all once again for your patient hearing.
Thank you. Thank you, Sada. That was indeed very precise.